Extradural Clinoidectomy.
In this episode of Neurosurgical Dissection in Motion, we demonstrate the technique of extradural anterior clinoidectomy performed through a supraorbital approach. The head is positioned with approximately 15 degrees of rotation and a slight extension. An eyebrow incision extending from the supraorbital notch to the external epicanthus is performed. Then we follow and extend this incision through the skin of the temple, following the most prominent wrinkle. After exposing the subcutaneous tissue and pericranium, the fascia of the temporalis muscle and the pericranium are incised about 2 centimeters behind the posterior orbital rim, just to ensure that we don't hit the frontalis branch of the facial nerve. An interfacial dissection is then performed to preserve the frontalis branch of the facial nerve, taking care to maintain this thin protective fat layer. The pericranial flap is then retracted anteriorly until the orbital rim is fully exposed. The temporalis muscle is then disinserted from the superior temporal line and is dissected downward, allowing for the exposure of the pterion. This step is critical as the pterion corresponds to the most anterior point of the sylvian fissure, what is called the anterior sylvian point. Supraorbital craniotomy is performed. Once at this point, we drill the sphenoid ridge flat with the superior orbital fissure, and it's at this level of the superior orbital fissure where we find this tent that is called the meningo-orbital band. This structure needs to be coagulated and divided, allowing for the incision of the outer dural layer and entry into the interdural space along the lateral wall of the cavernous sinus. This is called the interdural plane. At this point, the periosteal dural layer remains adherent to the periorbita and the cavernous sinus, while the outer dural layer is reflected laterally with the temporal lobe. We now expose the anterior clinic process. This semicircular contour of the optic canal is clearly visible and marks the most posterior end of the optic canal. Here we are going to perform 3 osteotomies that are performed sequentially to completely detach the anterior clinoid from the skull base. The first osteotomy involves drilling of the lateral sphenoid ridge, and this second osteotomy disconnects the roof of the optic canal from the superior orbital fissure. The third osteotomy consists of drilling of the optic strut below the optic canal and posterior to the internal carotid artery. So here we see how the optic canal is fully decompressed, and now the roof of this optic canal is removed with this non-drilled technique, and the lateral osteotomy between the sphenoid ridge and the optic canal are then connected. At this stage, the anterior clinoid process remains attached only by the optic strut. So the remaining ligaments attachments are carefully released, and the clinoid is drilled axially in the direction of the optic strut, which lies inferiorly to the optic nerve. A good trick to avoid injury of the optic nerve or the internal carotid artery at this step is to exhale the anterior clinoid process. By doing this, we'll just remain away from the posterior edge of the internal carotid artery and the inferior margin of the optic nerve. We are removing the last fragments of the anterior clinoid process, and here we expose the optic sheath and the internal carotid artery, along with the cavernous sinus. The dura is open in a C-shaped fashion, and a tangential incision is then made towards the optic sheath along the falciform ligament. The falciform ligament and optic sheath are open sequentially, and continuing inferiorly, the distal dural ring is incised, effectively mobilizing the internal carotid artery. This maneuver is particularly important in anterior clinoidal meningiomas as it reduces the carotid tethering and allows for a safer tumor resection. The ophthalmic artery is identified, typically arising from the supermedial aspect of the carotid artery. And finally, the dural flap that constitutes the external dural ring is reflected laterally to expose the supraclinoid internal carotid artery along with its distal branches, the anterior cerebral and the medial cerebral arteries. This finishes our exposures, so thank you for watching. If you found this video useful, please consider subscribing. Thank you.